Well, welcome. Another round, another day. Tonight we're talking about a very interesting subject called atrial fibrillation. We're going to learn everything about that. But before we get started, I want to share a few things. Is that on your far left, you can see the mask of the week there. Look at this gentleman here. He has his hat on. He has a mask that goes with his shirt. And if you look down what he has, what does he have next to that on that shirt there? Do you see that, Stuart or Paul?
That right there is a blood pressure monitor.
A blood pressure monitor. So we just did a webinar recently on blood pressure monitors. And what percentage of Ontarians or Canadians are going to develop hypertension in a lifetime? Anybody remember?
Yeah, that was, if I remember, it was around 90%.
Yeah. So 90% of us will develop hypertension over a lifetime. And one of the things is hypertension damages blood vessels, causes stroke. It also damages the heart and leads to more atrial fibrillation we'll talk about. So please, everybody, get a blood pressure machine at some point in time. It's something we should be measuring on a regular basis. There's Jen in the background. Jen is keeping us going, and she gets mad at me when there's too many people in the office and two people too close together. So, we now live in an era where if you're not 6 feet from somebody, you should wear a mask. And I think that's going to be here for a while, and we're going to learn how to deal with that better. And if you look on your right, well, that's it was my dinner. I got home around 10 o'clock at nighttime. Everybody's gone to bed. Carrie left me out. That's a little bit of carrots and one of your favorite sweet potatoes there, Paul. And
yeah.
And I really enjoyed that one. Then we had some whole wheat burritos. And and what's the number one protein in the world that it should be?
Beans, right?
Beans. So we had a bean burrito, and we had some nice yellow, orangey. And that was wonderful. Now, what we started recently, you can see. We have a little get-together, so I'm playing tennis. The day's getting shorter, and we can't start tennis till around 10:15 to 5:15 to 5:30 in the morning time. And so we're actually starting usually 5:30, but on the weekends we sleep in, and we're inviting everybody to come to Linden Park. You can see a picture there, Linden Community Centre, that's in Linden, Ontario. And they have 2 tennis courts. So I asked Dino what time he wants to start tomorrow. I thought he was going to let me sleep in, but we're starting at 6 o'clock. And but anybody who wants to join us afterwards, please do. And what we have here is a young son who's about 60, same age as myself, and his dad. Guess how old his dad is?
I want to guess 90.
He's 90 years old. He's playing tennis. Wow. 90 years of age. So that's great. He came out from Stony Creek, and he's going to come join us again. Hopefully this weekend. We have a few other people that are joining us. So we're going to have our Saturday and Sunday tennis. If weather is good, the court dries pretty quickly. So I'll get there with Dino around 6:30, and then anyone who wants to join us, come join us. And then at 11 o'clock, we're also going to meet for a bike ride. Work Saturdays and Sundays, so we're going to have a lot of fun there. So please join us. And one of the ways to prevent weight gain is that I think, which is important, is that to lose weight, you need to diet and eat less calories. To keep the weight off, you need to exercise. And so there are 1-2 combinations. So if you're not going to do both, good luck in getting the weight off. And one of the things that increases your risk of congestive heart failure and atrial fibrillation is your weight. So I'm working hard at that. I'm still stuck at 174. Yesterday was down to 172 for a while, but this morning back on the scale, 174. So I'm still not at my magic weight at 165, but I'm getting closer and closer, I keep saying, but we'll get there. I'm still 9 pounds away to where I want to be, and we'll see what happens. Next slide. Now, so I just want to share something. I'm always learning. We're always learning new things, and I think you've heard this before, but this is something called the Ischemia Trial. The Ischemia Trial took patients who had a mild to moderate angina who had lots of ischemia or lots of lack of blood supply to the heart demonstrated by a stress test or a nuclear medicine study. And if you go back to the webinar on cardiac testing, we have some more details. But if you look at this slide, this compares to having a bypass or angioplasty to best medical therapy. What do you think the difference is there, Paul? Do you see a big difference there?
Well, other than the fact that they cross, not too much difference right off the bat. And
Stuart, do you see much difference there at all? Emily, you see much difference there at all? Anybody see much difference there?
No, not too much.
Not much difference. So, you know, the surgeon always says, and we always say, you have blocked arteries, I got to you just in time. Well, if you look at people who have chronic disease, who have lots of lack of blood supply to the heart, there isn't much of a difference between having an angioplasty or having a bypass operation or good medical therapy. In fact, in the first 2 years before the curve crossover, you're more likely to have a heart attack or have a bad outcome if you have surgery or angioplasty. Because what you're doing is you're taking a stable vessel and you're cracking it and maybe doing a bypass on that. There wasn't much protection. There was actually a harmful effect of the procedure. And after from 2 to 4 years, there may be starting to see a benefit over time. So the message in this trial is that if you're waiting for an operation to make you live longer and you have chronic angina and you have blocked 2 or 3 vessels, doesn't appear to have an advantage. So how do you live longer? Well, let's go to the next slide. This is how you live longer. Optimal medical therapy. And there's about 60 things to do here. And one of them is lifestyle changes, being on medication. So people will say, how do I make sure I treat my heart disease? This is what you have to do. Now, I know this is small print for everybody, and we'll have a lot more discussions. That's what we're talking about, from lifestyle changes to good medical therapy. So what we learned, for instance, is that aspirin helps a little bit to decrease the chance of heart attack by 10 to 15%. What helps a lot are cholesterol medication. And so there's ways to make this disease better and to make you healthier. And so, and what we're going to learn in atrial fibrillation, and for the people who are presenting, so if I have atrial fibrillation, what is the best way to prevent a stroke? Anybody?
Sorry, Nate, you're going.
Yeah, so can everybody? Yes. You need to be on blood. So there's very few things in medicine that work that well. So you can actually lower the chance of having a stroke if you have atrial fibrillation by 60 to 70% by being on a strong blood thinner. Aspirin works a little bit, but blood thinners work a lot. So this is remarkable. So we're going to spend a lot of time talking about, learning about what is atrial fibrillation, and if I have it, how do I manage it better? So I want to start off today in saying is that I'm learning all the time. We've learned a lot, and we have better strategies. Next slide, please.
Okay. So we will get started. Like Dr. Cooney said, we're going to be talking about atrial fibrillation today. So some of you may have heard this term before. Some of you perhaps might not have. But I'm privileged to be joined by both Dia and Stuart today in discussing atrial fibrillation and its relevance in your cardiovascular health. And hopefully everyone can take something new away from tonight. But here we have an agenda of the things we're going to talk about. We're going to talk very, very briefly about palpitations in general before moving towards atrial fibrillation. We're going to talk about diagnosing atrial fibrillation. Dr. Cooney mentioned that atrial fibrillation and stroke are very much related, so we're going to talk about stroke for a little bit and how we can reduce that risk. We have some therapies for atrial fibrillation, lifestyle, as well as a little bit of new technology, because with the modern day, there's always a new piece of technology coming out every other day. So yeah, we're going to talk a little bit about technology too. So I'm going to start by passing it over to Dia, and she's going to tell us a little bit about palpitations.
Yeah, exactly right. So we ask you this question all the time in clinic. Have you ever been experiencing any heart palpitations? But what exactly do we mean by that? What are palpitations? The most primary symptoms of palpitation include a fluttering sensation in your chest. It feels like your heart is skipping beats. Perhaps your chest is pounding. There's a beating that's too fast in your heart. And there's also like a flip-flopping sensation in your chest. So not only will you feel these symptoms in your chest, you can also feel them in your throat and your neck. They can occur at any time, but the most common times that they can occur are during activity or when you're sitting or lying down for a period of time. If they are occurring, try and see if you can estimate how long they last and how frequently they occur as well. Next slide. So, whenever you're experiencing palpitations, they might seem worrisome. So the question that we always want to encourage is, when should you see a doctor? And to know the answer to that. So if you are experiencing palpitations, take a deep breath and check if your pulse is irregular. Heart palpitations are actually quite common, and they aren't always worrisome. If your palpitations are infrequent and last only a few seconds, evaluation isn't usually necessary. However, if you have a history of heart disease or conditions, your palpitations may have gradually worsened over time, and those are reasons to talk to a doctor. We also want to bring light to when you should seek immediate medical attention. So this includes when you're experiencing chest pain or discomfort, if you are fainting, if you have severe shortness of breath or any kind of trouble breathing, or if you're experiencing severe dizziness.
Let's go back to that slide again. So, what you're telling us is that feeling your heart jump, beat, skip beats, that's probably 90% of us. And the warning signs are when you're exerting yourself, you feel like you're going to pass out, or you have passed out. Or, I mean, I have aches and pains every day in my life. That means because I'm 60 years of age, that means I'm alive and kicking. So, heart pain is usually when you have this tightness, this heaviness in your chest. You feel sweaty, you feel uneasiness. So it has to be a pain that, if you're not sure what that pain is, obviously you want to have that investigated. But the pains that worry me is heart pain. And classic heart pain is not a pain, doctor. It's a weight. It's an elephant sitting on my chest. It feels like a weight. I feel sweaty and clammy. So that tends to be heart pain. I have this pain when I move my neck and my arm, and I have this arthritis in my back and sore shoulder. That's not the pain I'm worried about. I'm worried about the pain that comes on with exertion, or pain that just feels, it's just a new pain. You're not sure what it is, and it's a worrisome thing to do. What happens if you get dizzy when you get up quickly? What should you do?
Get up slower.
Yeah, blood pressure, exactly. So, and one of the things is that if you get dizzy and you get up quickly, is that measure your blood pressure. Let's find out what it is. We need some information here. We need to be, when you go to the emergency room, they do vital signs first. Right now, you go to the hospital, they get your temperature taken. But you at home should have your own blood pressure machine to keep track of. It's another more reason to have a blood pressure machine. The other thing too is that if you have diabetes, measure your blood sugar. Is that you could be having a low blood sugar. So those are things to look at. But thank you for sharing that. Perfect.
Okay. I also threw a very quick video in here because a lot of the time we'll ask if patients are experiencing an irregular heartbeat or symptoms of an irregular heartbeat or palpitations, and a lot of the time they don't really know what that is supposed to feel like. So we have a very short video in here describing that.
Ever feel like your heart is racing or like it skipped a beat? You may be experiencing heart palpitations, which can feel like your heart is beating too fast, pumping too hard, or fluttering. Usually lasting only a few seconds, they can also be felt in your throat, neck, or chest. And while they might seem a little scary, they're usually harmless. Lots of things can trigger heart palpitations, like anxiety, medications, or strenuous exercise. You could be at a greater risk of getting them if you're pregnant, stressed out, or have an overactive thyroid. If you have heart palpitations, schedule a checkup soon. In some cases, they may be the sign of a more serious condition, like an irregular heartbeat. If you also have dizziness, chest pain, or shortness of breath, get emergency medical treatment right away. Unless you have an underlying heart condition, you probably won't need any treatment. Just do your best to avoid the triggers that cause your palpitations. Stay away from stimulants like caffeine, nicotine, and energy drinks. And try meditation, yoga, or deep breathing to reduce your stress or anxiety.
Yeah, so a lot of the time, we'll think that we're having palpitations, but it just turns out that we're always just anxious, stressed, and drinking coffee all at the same time. And, if palpitations are normal, and 90% of us they are, sometimes they just take a little bit more push for you to start feeling them. So again, a lot of the time, you really don't need to worry too much about them unless you have some of the more worrisome symptoms, such as any fainting, or you feel like you're about to faint, shortness of breath, and things along that line, like Dia discussed earlier. Okay, so we're going to pass it over to Stuart to tell us a little bit about atrial fibrillation.
Thank you, Paul. So, as Paul mentioned, there's a number of reasons why you may have palpitations, but today's presentation is on atrial fibrillation, and oftentimes palpitations, if they become persistent or if they happen quite frequently, it can be a sign, a potential sign of atrial fibrillation. So let's talk about the condition itself. For starters, atrial fibrillation is one of the most common types of arrhythmia. Arrhythmia means an irregular heartbeat. So essentially what happens with atrial fibrillation is your heart is beating irregularly, and this causes your heart to contract in an irregular manner. If you look at the image on the top right there, you'll see that the heart has 4 chambers. At the top, there's the 2 atria, and at the bottom, there are the 2 ventricles. So there's 4 chambers in the heart. And essentially, if you look at the video at the bottom left, you can see that the top 2 chambers are the chambers that contract first. And what they do is when they contract, the chambers at the bottom are relaxing, and they're being filled up with the blood that's being pumped in. Then what happens after that is the ventricles, which are those 2 chambers at the bottom there, they're going to contract next. And they're going to pump blood out either to your lungs or to the rest of your body. What essentially happens in atrial fibrillation is there's these electrical signals in the heart, which helps to coordinate this system that I just talked about. What happens with atrial fibrillation is that this electrical signal becomes somewhat irregular. Paul, if you'd like to go to the next slide.
I love that animation. I love all this stuff. This is great.
So something really interesting about the heart is that it has its own little pacemaker machine. Essentially, it's basically operating with a mind of its own. It has these electrical signals that go throughout the heart. What happens first is you have this little bubble at the top of your atria right here, and what it does is it contracts first. It sends a signal throughout the atria, which is these 2 chambers at the top here, and then it sends this signal to this thing called the AV node. The AV node is then going to send signals through fibers all throughout the ventricles, and what that's going to do is it's going to help to push blood out to the heart, out from the heart, either to the lungs, or if it's in this ventricle over here, to the rest of the body. And this cycle repeats. It happens oftentimes if you're just resting about 60 times in just a minute. So this cycle repeats over and over and over again. What happens with atrial fibrillation, and if you want to go to the next slide, Paul, and as Doctor is going to show you right here, this is a video that's going to show you how atrial fibrillation works. I mentioned that the heart normally contracts with the top 2 chambers and then the next 2 chambers, but Dr. Jeff Nag right here is going to tell us a little bit about how atrial fibrillation leads to an irregular heartbeat.
There are a lot of patients who are very well educated about things such as stroke and what the consequences are, but there are a number of them who don't know what a stroke is, let alone why they're at risk of a stroke now that they've been diagnosed with atrial fibrillation. So I actually start off, and I've got a little handy tool that I share with them, and I'll start off right away by explaining what a diagnosis of atrial fibrillation means to them. So I start by using my foam heart to describe how in someone without atrial fibrillation, the normal way a heart works is the top half, or the atria, beat together along with the bottom half of the heart, or the ventricles. So blood will enter the atria, the top half of the heart, and then the top half will squeeze together, pushing the blood to the bottom half of the heart, and then it relaxes. When the blood's in the bottom half of the heart, the ventricles, it will squeeze, and pushes the blood out to the body, and then it relaxes. So put together, top half squeezes, relaxes, bottom half squeezes, relaxes. The consequence of atrial fibrillation is that the top half, or again the atria, aren't squeezing together. And what they do is, you can almost think of it as a bowl of jelly. They're just quivering. Right? So the consequence of that is that the blood can pool in the top half of the heart in the atria. Whenever blood pools, it's at risk for forming clots. And if the clots break off and go through the bloodstream, they can lodge in the brain and cause stroke. So that helps to explain the link between the diagnosis of atrial fibrillation and the subsequent risk of stroke.
So thank you, Paul. Paul's going to go a little bit into stroke and a little bit later in our presentation. But right now, as the doctor just explained, I have these really cool images right here that are going to show you the difference between a regular heartbeat and atrial fibrillation. So in your normal heartbeat, as I mentioned, you'll see that these top are contracting, and then it sends a signal to the bottom. This leads to this normal ECG. This is what doctor makes you do whenever you come into the clinic. And this leads to this normal ECG right here. As I mentioned as well, a normal heartbeat, there's usually about 60 beats per minute. Now, what happens with atrial fibrillation is it leads to this irregular contracting of the atria at the top. So the atria is not contracting synchronistically with the bottom ventricles. And this leads to that irregular heartbeat that you're seeing right here. You can definitely tell the difference between a normal heartbeat and one that's a little bit more sporadic with atrial fibrillation. So if we can go on to the next slide now.
So some people will not feel this at all. Mm-hmm. Sometimes you can detect it by just feeling the heart being irregular. Where normal sinus rhythm and normal heartbeat, it just feels very regular. So that's one of the clues. So some people don't like being in atrial fibrillation, and some people don't even know they're in atrial fibrillation.
Right, exactly. So atrial fibrillation, whether you know you have it or not, there are a number of different reasons why you may have developed it. Some things potentially maybe due to hereditary or age, things that may be out of your control. Sometimes there are also other reasons as well, such as high blood pressure, congestive heart failure, coronary artery disease, cardiomyopathy, diabetes or high blood sugar, some issues with your heart valves. It could be due to alcohol intake or being overweight. Now, there are a number of reasons, as I mentioned, why you may have atrial fibrillation, but there are also a lot of reasons why you may not even realize you have it. Sometimes it just happens in many people, and we just have to find a way to help manage it and take care of it. The concern with atrial fibrillation, and the reason why we have a whole presentation devoted to it, is because it puts you at a greater risk for things such as stroke or cardiovascular related complications. And so we'll talk about some symptoms in just a few minutes, but it's important to be able to understand and recognize the potential symptoms if you are symptomatic, so that we can, work with you to take care of these things. So Paul, if you'd like to move on to the next slide. As I mentioned, for some, the causes of atrial fibrillation can be easy to identify. It could be some sort of lifestyle change. It could be alcohol intake, a number of things. For many others, and it's quite common that the cause is not so obvious. And regardless of however you develop atrial fibrillation, there are many different ways that you can manage it. And that's the important thing right here in this presentation is we want you to get out all the ways that you can help to deal with this atrial fibrillation, whether it be through lifestyle, medication, diet, and exercise. And we'll talk about a number of things later in our presentation. So don't focus on what happened. It's really important to focus on what you can do next to take care of it. So there are a number of different types of atrial fibrillation. The first type that's quite common is known as paroxysmal atrial fibrillation. This is atrial fibrillation that comes and goes. It's often quite sporadic and short. It can last a few seconds, a few minutes. Sometimes it can last a few hours or days. Moving on to the next one, there is also one called persistent atrial fibrillation. Very similar, except this one lasts a little bit longer. It's often persistent for about a week or so. Next, we have long-standing or long-term atrial fibrillation. Atrial fibrillation in this case usually lasts longer than 12 months or so. And then the final one is called permanent atrial fibrillation, which is long-term atrial fibrillation that oftentimes does respond to medications, and sometimes it doesn't, and we have to help manage and deal with it in a number of different ways. But this is atrial fibrillation that is going to have to be managed sometimes slightly differently because it's persistent and doesn't go away, and so we need to take a unique approach occasionally to help deal with this permanent atrial fibrillation. And the reason why we talk about all these things is because atrial fibrillation is a serious concern for many people. As you can see, based on the Heart and Stroke Foundations of Canada, they have a statistic that says that mortality rate is doubled when atrial fibrillation goes untreated. So if you are symptomatic, it's important to be able to recognize these symptoms, and Dia is going to go through these symptoms with us shortly after this. Another statistic.
Realize is that atrial fibrillation, go back one slide, doubles the chance of you dying and increases risk of stroke by, I think, around 7 times, if I remember correctly. And if you have atrial fibrillation, you probably have a 60% chance at some point in your lifetime you will have a stroke if left untreated. And the strokes that you get are relatively big. And atrial fibrillation means that the heart is irritated in some way. The pressure or the volume in those small chambers are elevated. And as you pointed out so elegantly, it could be because your blood pressure is too high, you're overweight, you have blocked arteries, you have coronary artery disease, you drink too much. You can just see this goes on and on. So we have to figure out why you have atrial fibrillation and what you can do about it, how to actually decrease it. You also pointed out very nicely it could be all there all the time, or it can be there intermittently. So it's like so we have to find this out. It's also quite uncommon in younger people. In the age of 50 years of age, less than 2% of the population will have this. Over the age of 75 to 85%, up to 20% of the population can have this to different degrees. So it's something that we look at. So this is important to make sure, because as we're going to talk about, if you have atrial fibrillation, you have to decide what your risk of stroke is, and we're going to talk about that shortly. But don't ignore the problem. And I've seen so many people have strokes because they didn't recognize this, or they thought, well, I feel good. Let's find out. So you treat this disease to make you feel better and to make you live longer, specifically lowering the risk of stroke.
And a next statistic is an important one as well. A lot of times we don't think this can happen to us. But as you can see from this statistic, from the same resource, the validated Heart and Stroke Foundations of Canada, they say that 200,000 Canadians are affected by atrial fibrillation in 2020. That's a lot of people. So 1 in 4 cases of stroke in Canada of people above the age of 40 is related to atrial fibrillation. And the very important statistic at the end here is that people with atrial fibrillation are 3 to 5 times more likely to experience a stroke than those who don't have atrial fibrillation. So that is why we have a whole presentation devoted to it, and that's why Paul afterwards is going to be talking so deeply about stroke, how to recognize it, and why it's important to be able to manage it, manage atrial fibrillation, so that doesn't happen. So there are a number of different ways that atrial fibrillation can affect your life. So there are important ways to be able to manage it, either through exercise, with medications, and with diet. And the best way to manage it is to have a combination of all three. If you just do the exercise, as Dr. Kearney mentioned at the beginning of the presentation, but you don't supplement it with a good diet or take the medications that are prescribed to you and take them regularly and take them as they are prescribed, you're not going to be able to manage your atrial fibrillation as good as you can. So you don't want to be one of those statistics that we mentioned in the previous slide. So what can you do right now to manage it? There are a number of different ways. The good news is that there's many different steps to manage it. You can decrease your sugar intake. You can stay connected, which can definitely help to manage your stress and anxiety. Remain social, see your friends, give your friends a call all the time. Stay connected. That can definitely help manage your stress and your anxiety. You can also decrease your alcohol and caffeine intake, which is a very important one, which we will go into detail about. You can control your blood pressure and measure it regularly, and it's important to keep a log of it if you can, so that we can keep an eye on what your blood pressure looks like when you're not in the clinic. Next, important as well.
So just remember is that there are steps that you can do if you have sleep apnea, if you're overweight, you have high blood pressure that's not properly treated, you put yourself at high risk for atrial fibrillation and its complications. One of the things that we're learning about is that alcohol is not good for atrial fibrillation. Now, I'm not aware of any good data about caffeine, so I'm interested to see here if caffeine has a true impact or not. So I'm looking forward to hearing about that. But there's actually lots of very reasonable data that alcohol is what makes it worse. Mm-hmm. You can actually decrease the amount of atrial fibrillation by not drinking. Well, we'll learn more about that. Thanks.
Thank you. Next, again, as I mentioned, diet and exercise, and also smoking. Smoking cessation is a great way to help manage and control your blood pressure. And so being able to communicate with your health team, knowing your risks, knowing the signs, it's all very important to be able to manage your atrial fibrillation.
So Dia's going to tell us a little bit about diagnosing atrial fibrillation.
Yeah, so thank you, Stuart. That was a really, really good rundown of what it is and why we should care and pay a little bit more attention to what kind of symptoms that we're experiencing. So on the next slide, we're just listing a couple of symptoms of atrial fibrillation. These are similar to what we mentioned with palpitations. However, palpitations are included in the symptoms. So you'll be experiencing some kind of palpitations, typically weakness, a reduced ability to exercise, fatigue, lightheadedness, dizziness, shortness of breath, and sweating. So we also want you to keep in mind that these symptoms listed, we're looking for anything that's abnormal. So not something that's typical. For example, if you get lightheaded after a really stressful day, and that's common for you, then that's not necessarily a symptom that you should watch out for. And we're talking about excess fatigue and excess weakness. Also, there are many cases where individuals don't experience these typical symptoms. This is called asymptomatic atrial fibrillation, like Dr. Kearney mentioned. In this case, they won't experience these symptoms that are listed, and they may only experience a little bit of fatigue or weakness. Both asymptomatic and symptomatic atrial fibrillation can be diagnosed using an ECG or Holter monitor, which is why almost everyone at the clinic gets an ECG done every time they come in for a checkup. This brings us to our next slide. Now that we know the symptoms, how do we test and diagnose atrial fibrillation? So it depends on the symptoms that you are experiencing. There are several methods of diagnosis. If you're experiencing palpitations and other symptoms, you can use an ECG, which records your heart's electrical activity, as Stuart put on the slides earlier. If you're experiencing sporadic or infrequent episodes, you can use a Holter monitor, which records your heart's electrical activity for a longer period of time, 24 to 48 hours. If you're experiencing paroxysmal symptoms, which happen as intermittent episodes, you can use an event or loop monitor. So these are typically worn for 1 to 2 weeks, and either you activate them whenever you're experiencing an episode of symptoms, or they activate themselves. Or you could be tested in a catheter lab through an electrophysiologic study. And finally, if you are having activity or exercise-related symptoms, a stress test is always the best way to go.
Yeah. So one thing to keep in mind. Oh, yeah, Dr. Kearney?
Go ahead, Paul. Go ahead.
Yeah, so one thing to keep in mind is all of these tests are using a very similar principle, or they're testing for very similar things, and that is the electrical activity of the heart. So every time you come into Dr. Kearney's clinic, we take an ECG, just because we're able to find so much information with so little with the ECG. This is what we see when we take your ECG and pull it up on Dr. Kearney's big bright screen. I'm not going to teach you how to read this. I think, unfortunately, you might have to go to medical school for that. But I will try. I can explain some things that we typically look for. So one thing is
atrial fibrillation is easy to recognize. Everybody,
it's easy to recognize.
Watch the cardiac device, In fact, we're actually not even doing loop recorders as much anymore. So we actually replace loop recorders with 14-day Holter monitors sometimes. Now you can actually diagnose yourself. And so Paul's going to show you that, how to diagnose yourself.
Yeah, so let's say you have your ECG right in front of you. I also should probably put a little disclaimer that this is not to be replaced with a real medical consult. But let's say you have your ECG printed out in front of you. There's two key things that we look for atrial fibrillation. One, you'll notice each of these little spikes, right? So these are things that Dr. Kearney looks for when looking at your ECG. Each of these big spikes represents a heartbeat of the ventricles, or the lower half of your heart.
The big half.
Normally, the big half of your heart. Normally, these spikes should be evenly spaced. You want an even amount of space between them. However, if Dr. Kearney looks at your ECG and he sees something like this, you'll notice that they're not evenly spaced. There's a big space here, you have a small space, a medium-sized space, and then a bunch of small spaces, some bigger spaces. They're not evenly spaced. So what that tells us is that there's some sort of disorganization there. Some signals are getting through, sometimes they're not. And there are very sporadic signals going on within the heart. So one sign we look for is uneven spacing. The second big thing that we look for is a lack of P waves. So obviously there's a lot of things on this graph here. It's kind of bizarre to even think that, just a series of lines could tell you so much information. But trust us, there's each of these one little spikes is made up of a whole bunch of pieces. Normally, before one of these spikes, so if you remember, these spikes are the electrical signal in the big half of your heart. Normally, you have this small little upward hill in front of these spikes that would represent the electrical signal in the smaller half of the heart. You'll notice here, you're missing these small hills right in front of these spikes. So it's just flat, and then you have a spike. Here it's flat, and you have a spike, and flat, and you have a spike. So that is what Dr. Kearney would think in his head is a lack of P waves, is what we call it. So in atrial fibrillation, there is big spaces and small spaces, a mix of big and small spaces. Normally, it's pretty even, and you're missing the hills in front of these spikes. With those are the two key things. If you ever buy your own ECG machine, you can slap it on yourself and pretend like you went to medical school.
This is actually important right now because we're now doing self-monitoring. So this is actually a 12 lead or 12 look at the heart. You now can get things like the Apple Watch or the cardiac device that can on your watch or on your iPhone can detect if you have atrial fibrillation or not. The key to this is that you need to have good contact, and sometimes we can actually have bad contact and we don't see the P waves or the little spikes in front of those big QRS complexes, and we can sometimes get artifact in the way. So one of the things that I've learned, and early in my career, I sometimes have called artifact or just poor lead contact atrial fibrillation. So I learned to recognize this. So one of the things for those of us who are going to enter this new technology, this is what classic atrial fibrillation looks like, and sometimes artifact can look similar along the way. So that's why we spent a little bit of time telling you about this over here. So I'm not making doctors out of you, but that's something that's becoming more and more important because we're going to self-diagnose ourselves more and more.
Yes, and on the topic of the technology, I actually talk a little bit about the Apple Watch and self-monitoring of atrial fibrillation towards the end of the presentation. So, some of the newer Apple Watches can actually tell you if you're in atrial fibrillation, and I'm going to discuss that in not too long as well. But before we do move on and get to that, I am going to start talking about stroke. So, just for the past 40 minutes, we've mentioned stroke many times, and that's because atrial fibrillation and stroke are very much related. So it seems kind of bizarre or perhaps unique that a problem with the heart can lead to a problem in the brain. They seem like they're literally more than a feet away in myself at least. So yeah, but they are very related. So you can't think of atrial fibrillation without considering the risk of stroke. Like Stuart told us earlier, people with atrial fibrillation are 3 to 5 times at higher risk for stroke, and 1 in 4 strokes over the age of 40 are caused by atrial fibrillation. So atrial fibrillation plays a huge role in strokes, and I'm going to talk about how that happens. So here we have the video that Stuart was showing us earlier. So again, you have 4 chambers in the heart, 1, 2, 3, 4. So it's these upper chambers that are called the atria. And in atrial fibrillation, this is where there's disorganization and dysynchrony, and a lot is going on in the atria that isn't normal per se. So atrial fibrillation, so the thing is, when you have atrial fibrillation, like Stuart showed us in the video, this can lead to pooling of blood in the atria because it's not pumping properly. And I'm going to talk about blood clotting in not too long as well. But yes, atrial fibrillation increases the risk of stroke. Other things to keep in mind are hypertension, diabetes, and heart disease. And again, when it's irregular and disorganized, and this stagnates the blood, so blood stays still, for example, for some period of time, or blood is around and not moving throughout the body for some period of time, it can create a clot, and this can travel to your brain. So let's talk about blood clots for a second. Here we have Chef Curnew. So we know Dr. Curnew loves his forks over knives, and he loves practicing cutting. So this little bit is based on a true story. We have Dr. Curnew, and we have Dr. Curnew's hand. So I remember there was this one time when Dr. Curnew was practicing his cutting or his cutting skills, and he got a cut on his finger. And when you get a cut on your finger, let's say you are in the kitchen and you're cutting and you cut your finger, you start bleeding. But you'll notice after a little while, the bleeding eventually stops. And that's because inside the blood, there are a lot of various proteins and a lot of very special substances in the blood that will help stop the bleeding. The thing is, this is reliant on the blood regularly moving throughout the body. So blood has to consistently be moving throughout the body. Issue is with atrial fibrillation, if you remember, we said the atria become disorganized, or the upper chambers, the smaller chambers of the heart become disorganized, and blood can sit still or sit in the chambers for some period of time. If blood is sitting there for an excess period of time, a lot of these special, unique proteins in the blood that help us when we get a cut and are bleeding actually work against our favor. They can sort of stick together, the blood can stick together and can form a blood clot. Now, when this eventually does get out of the heart, so it does pass through the heart eventually at some point in time, this can reach the brain, and it can block the blood to the brain and cause a stroke. Now, there are a lot of risk factors for stroke, and we actually have a scoring system for risk factors called the CHADS score. So each of these letters, so CHADS, stands for something, or an important risk factor. First off, we have congestive heart failure. So if you have heart failure, you are at increased risk of having a stroke. I should also mention that this score, so these risk factors are for the risk of stroke in people who have atrial fibrillation, but it does also work in people who don't have atrial fibrillation as well. But if you have atrial fibrillation and you have congestive heart failure, you're at increased risk of stroke. If you have hypertension, high blood pressure, then you are also at increased risk of stroke, even if it's treated with medications. If you are of older age, so greater or at 75 years old or greater, again, this increases your risk of stroke. If you have diabetes, your risk of stroke increases once more. And if you have history of stroke, so if you've had a prior stroke or a prior disorder related to clotting, like peripheral vascular disease, for example, then you are, again, at increased risk of stroke. You'll notice on the side here, I've written some points. I'm not going to talk about those just yet. I will come back to talking about what these points mean. But some things to keep in mind: congestive heart failure, high blood pressure, older age, diabetes, or previous stroke, you have to be really, really careful with your risk of stroke, and making sure that you are doing everything in your power and communicating with your healthcare professionals to reduce that risk.
Now that's quite interesting. If you just go back to that, is that one of the things is that we take arbitrary numbers. So age 75, in fact, the higher points, the more the higher risk of stroke is, that we're going to learn in a few minutes. But there's nothing magical with 75. In fact, the risk of stroke is quite low on the age of 50 years of age, and it starts to go up. And in fact, once, from 50 to 60, your risk goes up. And 60 to 65, now 65 is actually significantly higher, and many scoring systems now use an age over 65, such as the Canadian Cardiovascular Society. So, over the age of 65, your risk is up quite a bit. In fact, we're actually doing a trial called Brain AF in younger people below the age of 65, seeing is that, and we're finding out that even younger people without some of these risk factors can have stroke. So I'm now using 65 as a cutoff for anticoagulant therapy at the Canadian Cardiovascular Society. And so these are things to think about. So CHAD, C for congestive heart failure, H for hypertension, A now it's the age of 65, D for diabetes, and S for stroke or TIA. The best predictors of stroke, unfortunately, are having a previous stroke in the past, and next comes age, as you can see. And so these are actually important things to remember. Go ahead there, Rob.
Yeah, so that's a very good point you brought up, Dr. Kernew. I do want to recall a statistic that we shared from the Heart and Stroke Foundation that 1 in 4 strokes over the age of 40 are caused by atrial fibrillation. So, just because you are 74 years old, not 75, it doesn't mean that, you're safe from stroke. And like Dr. Kernew said, we're always learning new things. Right now, Canadian Cardiovascular Society is using the age of 65. That might even lower at some point in the future as well. I don't have a slide on this, but I do want to very briefly cover the warning signs of stroke. So there's a very good acronym to remember, and that is FAST, F-A-S-T. So F stands for face, if you have drooping in one side of your face. A stands for arms, so if you have weakness on one side of your body or one of your arms, you have trouble picking it up. S is for speech, if you have slurred speech or you have a lot of difficulty speaking. And again, all of this being on one side of your body. And T is for time. So I really like that this acronym is called FAST, and T, the last one, T, stands for time, because if you notice these signs of stroke, you have to act very, very fast. Stroke is very, very important, and success on treatment of or immediate ER treatment of stroke is reliant on the speed that you get to the ER, the speed that you call 911 and get this treatment as well. So again, sorry, Dr. Kernew?
If you think you're having a stroke, what you do is call 911, get to the hospital, get to an emergency room as quickly as you possibly can. Now, there are specialized stroke centers in Hamilton. It's the Hamilton General Hospital. If I think I'm having a stroke, I'm getting someone to get me to the Hamilton General Emergency Room in a very timely fashion, because minutes mean brain damage. And the quicker you get treatment, the better off you are. As you point out, causes of stroke, atrial fibrillation is a bigger cause, especially as you get older, but you can also have blockages in your neck called carotid disease. And if those blockages break off and go to the brain, is that we now have the ability to use blood clot dissolving agents, and in some institutions, balloons to get those clots out of the blood vessels in your neck. So if it's coming from your heart, it's a big blood clot. Coming from the neck, it's usually a smaller blood clot. So if you think you're having a stroke, you need to be in an emergency room that can treat, and the best emergency room in this area is the Hamilton General Hospital. But saying that, if you're not close to the Hamilton General Hospital, any emergency room is a place to be. So this is time is brain. This is a medical emergency. Okay, thank you for bringing that up.
Yeah. So again, just to reiterate one more time, for stroke signs, that's fast. F for face, A for arms, S for speech, and T for time. You have to act very fast. Okay, so we're going to move on to talk about therapies and how we actually can treat atrial fibrillation. So we're going to talk, and I guess this is more so medical treatment of atrial fibrillation, and Stuart later on is going to talk about lifestyle changes as well. So when you manage atrial fibrillation medically, some of our goals include reducing the frequency of atrial fibrillation episodes, regulating this disorganized rhythm. Atrial fibrillation a lot of the time is found with a really fast heart rate just because there's so much disorganization. So another goal is decreasing this fast heart rate, reducing stroke risk. As we've just talked about, stroke is very important and very much related to atrial fibrillation. So in cases where patients do have atrial fibrillation, you not only treat atrial fibrillation, but you also treat for the risk of stroke. And if applicable and a patient is symptomatic, then minimizing symptoms is also a treatment goal. So I'm going to very briefly talk about rhythm medications. So this affects the disorganized beating of the heart. Blood clotting medication, so this is going to be regarding reducing the risk of stroke. And very briefly, one slide on ablation. So rhythm medications, or also referred to as antiarrhythmias, like Stuart told us earlier, an arrhythmia means an irregular heart rhythm, an irregular heartbeat. So antiarrhythmia simply means treating irregular heartbeats. So rhythm medications work to reduce the fast heart rate and the disorganization or the disorganized beating seen in atrial fibrillation. So rhythm medications treat arrhythmias. However, if you're prescribed rhythm medications by Dr. Kearney or a doctor, be sure that you get your blood work done regularly. You're checking in with your doctor, communicating, noticing any changes in your symptoms, because some rhythm medications work in two directions. They can treat rhythms, but they can also cause changes, different changes in your heart rhythm as well. So be careful, or be sure to be cautious and keep track of your health when you are on these rhythm medications. One of our first choices are what's known as calcium channel blockers. So if you are on diltiazem or on verapamil, then you are on a calcium channel blocker. Now, again, this is a first choice because this allows for long-term rate control. So it's not a very short-term drug, it's more of a long-term drug. And again, if you have atrial fibrillation, then you do have atrial fibrillation for the rest of your life. I guess with the exception of ablation that we might talk about. But yeah, so you would be on this medication perhaps for the rest of your life. Calcium channel blockers can help make the disorganized beating of the smaller chambers or the atria more controlled and organized. Some of them, or diltiazem specifically, can also lower your blood pressure. So if you have, or we talked about how high blood pressure is also something that we have to be considerate of in atrial fibrillation and risk of stroke. So this is sort of a 2-for-1 deal where it can lower your blood pressure as well as control the risk, or help control the rate in atrial fibrillation. Beta blockers are sometimes secondary drugs in atrial fibrillation as well. A lot of you might be on beta blockers for reasons that aren't atrial fibrillation. The same goes for calcium channel blockers. These are drugs that are not specific to atrial fibrillation, but they do help in atrial fibrillation. So beta blockers help in atrial fibrillation by lowering the heart rate. So like I said, atrial fibrillation is sometimes very fast. So it lowers the heart rate and it also lowers the contractility. So you can imagine if your heart is having a spasm, or you notice sometimes a good analogy to the atria might be sometimes you notice your eye randomly twitching, and sometimes it twitches really, really hard. So it lowers the rate of the twitching of the atria or the contractility of the entire heart, and lowers the heart rate as well. So these are very common medications: metoprolol, bisoprolol, atenolol, esmolol. Esmolol is a very, very short-term beta blocker. It's sort of, has a very short duration, but it's sort of, if you're noticing very severe symptoms and you want to treat those right away. Digoxin is a medication that you might be on, especially if you have congestive heart failure or if you are very, very sedentary. And so what digoxin does is it sort of slows down the entire heart altogether. There's this principle called vagal tone. So it's along the lines of our fight or flight response, as well as the sleep and digest response. So you can imagine if you're being chased by a bear, you don't really want to worry about having to control your bladder. But so these are two different systems. You have a relaxed system in the body and a very excited system in the body. And so digoxin emphasizes the relaxed system in the body and essentially slows down the entire heart. Now, this is really important for patients with congestive heart failure, again, because CHF, or congestive heart failure, does also increase your risk of stroke.
Well, if you look at these medications, so my initial thoughts are, for most people, if your heartbeat is too fast, you got to slow it down. If it's too slow, need a pacemaker. But the traditional medications that I approach right now is that diltiazem and verapamil. These are calcium blockers that actually affect the two small chambers and something called the AV node. To me, I don't use them first-line therapy for most people because what they can do sometimes is make the heart pump less forcefully, and for people with a weak heart, that can make congestive heart failure worse. Whereas I like to use beta blockers first if I can, because if you have a weak heart, they can actually strengthen the heart, make the heart stronger, and they slow the heart rate down. Now, in people that have asthma, you might have to be cautious about using beta blocker therapy. And also is that not all calcium blockers, amlodipine or Atilac or Norvasc, or other calcium blockers, but they don't affect the heartbeat. But these are all medications that affect heartbeat are important. And digoxin is an old friend. It's basically it affects more called the AV node, the connection between the big chamber and the small chamber. And so that's useful in people who have atrial fibrillation, whose blood pressure is lower, and when they're in a normal heartbeat, the heartbeat's low to start off with. So we have lots of choices here. Esmolol is a drug that we use in the emergency room. It's only available intravenously at this stage. So you can see that so the strategies to lower heartbeat. So one of the things, if you do have a slow heartbeat from atrial fibrillation or a fast beat from usually going too fast, you can slow it down. So it gives you another reason to monitor your pulse and your heartbeat. That's fantastic. And now you're going to go through something called amiodarone, where the first three drugs are to slow heartbeat. Amiodarone is a drug to actually prevent atrial fibrillation. Go ahead there, Paul.
Yeah, exactly. So you've already said it for me. Amiodarone is a drug to help prevent atrial fibrillation. So one of the causes of atrial fibrillation could be structural heart disease. So perhaps you've had some sort of damage to the heart. Now, if you imagine the circuitry within your house, you can compare that to the circuitry or the electrical system in the heart. If you have some fuses that are blown in your house, things aren't going to work exactly like you want them to. So you're going to have to call an electrician in and deal with those fuses. If you have structural damage or damage to the conduction system or the electrical system of the heart, you have to do something to help treat that as well, which is where amiodarone comes in. One thing that Dr. Cooney mentioned that I do like is, and perhaps even more important than knowing the specific medications, unless perhaps you are on these medications and this information is more valuable to you. But if you're not on these medications, then some things that we look for, the general trend is a lot of these medications will help affect the disorganization of the heart and will lower the fast heart rate. Like Dr. Kearney said, if you have a fast heart rate, we treat that with medications. If you have a slow heart rate, that typically requires a pacemaker. So these are a lot of the medications for rhythms. And again, it's about creating organization within the heart. Now I'm going to talk.
So if you go back one slide there, so amiodarone is a very special medication. I basically my initial approach for many people is to try to slow down the heartbeat. And by slowing and controlling the heartbeat, most people feel improved. Now, if some people just don't like being in atrial fibrillation, the fact that you lost the atrial, the small chamber contribution to your heart, can really drive some people crazy and make them feel uncomfortable. In that circumstance, we need to use strategies to maintain the heartbeat at normal beats. And amiodarone is probably the most important and one that has the most side effects if we're not careful. It has much higher success in maintaining a normal heartbeat. We have other antiarrhythmics that go some things like flecainide or Pafanon. But when you start using these drugs to maintain normal sinus rhythm, they do have more side effects, and we have to be careful when to use them or not. That's an individual consideration. For instance, if you're on amiodarone, we know that about 5% of people will develop an underactive thyroid, and 1% will develop an overactive thyroid. It can affect the skin, give you a bluish discoloration, more prone to sunburning. It can affect the liver in different degrees. And what amiodarone does is the longer you take it, the more you take it, the more likely you have side effects. So usually if you're the age of 65, 75 years of age, you need a little bit of amiodarone to control things. But if you're a younger person, I won't be using amiodarone because the toxicities are related to how many years you've been on the medication for. So this just gives you a little glimpse of what we're thinking about. But for most of us, slowing the heartbeat is killing atrial fibrillation. The heartbeat tends to go too fast for people. And it can go fast and slow. That's called the tachybrady syndrome. So lots to learn here. And thank you for sharing that, Paul.
Okay.
Importantly, you want to prevent stroke, and that's what Paul's going to tell you about right now.
Yeah, so next I'm going to talk a little bit about clotting medications, also known as anticoagulants. So as you mentioned, stroke is a very real concern with atrial fibrillation, and clotting medications help reduce the formation of clots. So if you remember, in atrial fibrillation, the atria are disorganized and there's pooling of blood in the atria. This can form clots, and clotting medications can help either break these down or prevent the formation of them as well. Now, we have a very old drug called warfarin. So a lot of you might be very familiar with warfarin. Warfarin is, I guess, the classic anticoagulant that's still used, at least. And I'm going to talk a little bit about how it works. It basically antagonizes vitamin K. Vitamin K is important for activating those very special substances within the blood that will help create clots. So warfarin, one of the main reasons why warfarin is used, especially still with newer therapies, is that it is a very cheap drug. It's about 10 cents per day. So you can get a lot of benefit out of warfarin for a low price. However, warfarin is a difficult drug to use, and the reason for that is because you have to monitor this value called INR. So if you're on warfarin, you have to get, at least for the first while, you have to get a blood test pretty much every month, and the blood test is going to tell you about this INR value. Now, you'll notice this image here. We have thromboembolic, and this is your risk of forming a clot, and hemorrhagic. This is your risk of bleeding. So it makes sense, if you are reducing the formation of clots, you simultaneously increase the risk of bleeding. For the same reason, if you remember back to the example with a kitchen knife, if you cut yourself, the clot is the reason why you stop bleeding. If you're on blood thinners and you cut yourself, it's going to take a lot more for your body to stop that bleeding. And so you can actually bleed a little bit more or a lot more depending on where the bleed is when you are on blood thinners. So with warfarin, it's hard to even prescribe an initial dose. And the reason is because everyone has almost a unique dose of warfarin that works for them. It takes a lot of trial and error, so patients have to try this dose, and then this dose, and then they might try, 8 milligrams once a day, then they might break it down to every other day, and then try 3 days on, 4 days off, or 4 days on, 3 days off. It's just a whole bunch of testing before they're able to find a dose that works for them. Now, the dose that works for a patient that is on warfarin is, upon getting these monthly blood tests, it's when they have a stable INR value that's between the values of 2 and 3. Warfarin, while it's cheap, it's a very, very tedious drug to use, in that patients need to get a lot of blood tests. They need to continuously adjust their dose to make sure they're in this value. It takes a lot before someone comes to a unique value that works for them, and even then, that value can still change as well.
So, saying that is that we've had a lot of experience on warfarin therapy, and we have a great thrombosis service at the Health General Hospital. Countries like Sweden have a very organized approach. So initially, when you start on warfarin therapy, you go for a few days with usually with warfarin, then you measure the blood test called the INR. So when you first start, you're going to be probably measuring blood INR values maybe 2-3 times a week. And as time goes on, once you get stabilized, you can actually measure it once every couple of weeks to once a month. I would never let it go longer than once a month. And some people now have their own machines at home. You can actually regulate it yourself. There's a lot of people out there that it's kind of easy to control. They're very stable. You know what you're doing. It works quite well. There's also a group of people who are very unstable on them and that you can't control well. Why? Because they may be drinking alcohol. They're changing their fruits and leafy vegetables on a regular basis. And more importantly, they're not telling the doctor the truth. Is that, if blood thinners work if you take it. If you don't take it, you can't get a good proper value. And if you don't in the proper therapeutic range, you're more likely to have a stroke. If you take too much, you bleed too much. If you don't take enough, you have a stroke. And that's what that curve show you here. So message number 1, blood thinners work if you take them properly. And I must stress is that many of us don't take our pills properly. Warfarin is one of those unforgiving medications for any blood thinners. In fact, warfarin is a little bit more forgiving than the newer direct NOAC that we're going to talk about, because the new agents go in your system quickly and out of your system quickly. Well, warfarin takes a number of days to get into your system to get their therapeutic range, and it goes out of your system. So if cost is a factor, then warfarin is a fantastic drug for you. I also stress, if you're a patient who doesn't take their medication properly, I prefer to think about being on warfarin therapy, because I know if you're taking it or not. If you take some of the newer agents that Paul's going to tell you, I don't know if you're taking it or not. I have to rely on you telling the truth in that nature as well. And I can stress this is that we all make mistakes. We're all going to get things wrong. But this is one of the drugs you don't want to get wrong. You have to really be attentive to detail in this circumstance.
Yeah, and like Dr. Finney said, anticoagulants, if you are on anticoagulants, this is perhaps one of the drugs that you want to be less rebellious on. It's sure I don't want to take my drugs, but if that's the case, you can't only do half of it. The reason is because if you take too much of these drugs, you are at higher risk of bleeding. You'll notice that the bleeding risk shoots up. If you take too little of these drugs, you are at higher risk of stroke. You'll notice that the stroke risk shoots up on this side here. This is one of those drugs that, sure, you can make mistakes, but to rebelliously reduce your intake, or just take it every other day, or just not follow what's prescribed just because you don't want to, this is a very risky thing to do to yourself.
Most patients are looking after themselves can take warfarin pretty safely. Next, tell us about the NOAC.
Yeah, so here we have direct oral anticoagulants, or also known as novel oral anticoagulants, so DOACs or NOACs. There are a lot of them. I've listed a few of them here. So Digoxin, rivaroxaban, apixaban, and doxaban, with their trade names here. So a huge pro for DOACs is that you don't need to get a lot of those blood tests. For the first week, you're not going to have to do blood tests 3 times a day. not going to have to do the monthly blood test, so you don't need to monitor the INR when you're on these newer medications. However, on the con side, these newer medications, at the cost of not having to monitor your INR levels, they are more expensive at the same time. So the trade name, which is the ones that are in these brackets, on average is about $3 per day. So Pradaxa, about $3 per day. The generics, so Paxaban, Digoxin, or Digoxin, the generic medication is about $1.25 per day. So generally,
so just to say right now is that all the drugs are trade names, except right now in Canada the only generic drug is the Digoxin or Pradax is generic. The rest are trade names, and basically there's laws and rules about when a drug gets genericized. So trade name is basically proprietary rights of a company, and once it's a certain lifespan, other companies, usually generic companies, other companies can actually make copies of the medication. There's very stringent rules about that to start off with. So, so you can see that warfarin is 10 cents a day. These newer agents are about $3 a day. The Digoxin now is available in a generic form in Canada. These are going to change as time goes on. So there's a big difference in cost, but there's also different bleeding risks that Paul's going to tell us about too as well.
Yeah, so you might be wondering, if you have atrial fibrillation and you have perhaps equal access to both of these, to both warfarin and DOACs, which one might be better for you on atrial fibrillation? So before I tell you about that, I have a lot of text on this page. You don't have to read it all. But like Dr. Cooney said, the Digoxin is available in Canada as a generic name. And although it is $1.25 per day if you were to pay out of pocket, there is something called an LU code. Now, what an LU code is, if you qualify based off certain criteria, the government can actually... Yeah, so this is for Ontario. The government can cover the medication for you, depending on various plans that are available. However, you'll have to notice that in order for you to qualify for this, for Digoxin or Pradaxa, 1, you have to be on non-valvular atrial fibrillation. 2, you would have to have tried warfarin for at least 2 months consistently, and you would have to have found that warfarin wasn't effective at reducing your clotting. 3, you would have to have one of the other factors on the CHAD score. So that's congestive heart failure, hypertension, above the age of 75 or 65 for the Canadian Cardiovascular Society, diabetes, or previous stroke as well. And there's a whole bunch of other things. You need to have good kidney function above the age of 75. Just a whole bunch of things that you need to qualify in order to get the Digoxin covered. However, it is possible to get covered, and you can have this conversation with your doctor to help determine whether you would qualify for that or not.
So to summarize a few things is that if you just go back 2 slides, is that go back one more slide, is that we have many choices, and when you play golf, you have many clubs to choose from. And I think right now is that as time goes on, we're using these newer agents much more liberally, because number one is that you don't have to go for monitoring. And if you're a compliant individual, you have a predictable dose, and you don't have to actually monitor anything, provide your kidney function remains stable over time. They also decrease the chance of intracranial bleeds or bleeding inside your head by 70% compared to warfarin therapy. So they're safer when it comes to bleeding inside the head. The most common form of bleeding still is through the GI tract. And some of these newer agents actually cause more bleeding in the GI tract. Some are equivalent. So it's a complicated answer that you need to sort out with your healthcare team. Remember is that I want you to be on a form of an anticoagulant. And if you're at higher risk of bleeding, especially risk of falls in older patients, you're more likely to have bleeding inside your head. So we often skip some of the government's criteria, or we look at the government's criteria, is that the government says if you can't take warfarin because you're contraindicated, you can use these newer agents. But we're not wanting to use them for convenience. We want to use them to prevent stroke. And there is a difference in cost and how to assign value and things of that nature is something we need to look at. So I'm really pleased that we have many agents available, and these other agents have different properties into them that look at that as well. So this is not meant to be, medical school about how to be on blood thinners, but if you have atrial fibrillation and your CHAD's 1 or greater, you need to consider, or you should be on a blood thinner. And what scares me is that people decide not to be on therapy or to stop therapy. The consequence of that is stroke.
Okay. Thank you, Dr. Kearney. I'm going to move on to talking about bleeding risk. So let's see, I think I do have, yes, the ENGAGE trial right after this. So bleeding risk is, you'll notice that for the past few slides, we have been talking about balancing the risk of stroke with the risk of bleeding. And like Dr. Kearney said, one of the most common areas for bleeding right now is in the GI tract as well, or your intestine system around there. So when you are on blood clots, when you are on anticoagulants, though it reduces the formation of blood clots, you are at higher risk of bleeding. So bleeds, you can have a big hemorrhage, so perhaps some sort of damage within your GI tract, or an artery somewhere could break. You could have scarring, external damage like a cut that has reduced scarring. There is a type of stroke that is actually not the classic stroke we think about. It's called hemorrhagic stroke. You can actually have a type of stroke that is caused by excessive bleeding. So hemorrhagic stroke is when the arteries in your brain, so the vessels that supply blood to your brain, can tear, and blood you can bleed out a lot within your brain. And then, the same way that blood dries on your skin, blood can dry within the brain, and it can kill some of the brain tissue there as well. And it can also cause increased pressure and just do a whole bunch of things to your brain that aren't very pleasant. That's what's called a hemorrhagic stroke. And this is a stroke that can be caused due to excessive bleeding. On the other hand, ischemic stroke is the stroke that we most commonly refer to. Typically, when you just say stroke, we're usually referring to ischemic stroke. And this is when you have a blood clot that blocks off the artery. You have reduced blood to that area, and therefore reduce the oxygen. As we know, our bodies need oxygen to survive. So it's really important when you're on anticoagulants that we're very considerate about the dose. If you're on warfarin, you're between the 2 and 3 range in your INR, in order to balance the bleeding risk as with the ischemic stroke risk. Now I'm going to talk about the ENGAGE trial.
Again, I'm sorry, just one more point is that hemorrhagic stroke is a disease that can be prevented in many individuals by treating the blood pressure. So controlling blood pressure, we see a lot more hemorrhagic stroke. If your blood pressure is too high, you can damage the vessels inside your brain. Where atherosclerotic of the blocker of the neck is treated by things like cholesterol, blood pressure, etc. Also, as you get older, your vessels get more friable, and sometimes the blood thinners can be a detrimental effect too as well. So we have to balance this. So that's why if you think you're having a stroke, what do? Call 911, get to the hospital. You need to have imaging of the brain to decide what to do. If you have the situation of a hemorrhagic bleed inside your brain, that therapy is avoidance of blood thinners. You need to consider reversing that process. But on the other hand, if you're on the right, you have an ischemic stroke where you have that blood clot in that carotid artery. We have blood clot dissolving agents that we can use, maybe catheters to go get the clot out of that vessel as well. So you can see you really need to think about what's going on, and you need to have imaging. So that's why stroke is a medical emergency, and you don't want it's not a place to be at home. If you think you had a stroke or a warning stroke, get to the hospital. Get to a stroke center if you know where one is. In Hamilton, it's the Hamilton General Hospital.
Wonderful. Thank you, Dr. Kenya. I'm going to very briefly talk about the ENGAGE trial. So the ENGAGE trial is a trial that looked at atrial fibrillation and compared warfarin, so the older anticoagulant, to edoxaban, which is one of the newer anticoagulants. So it's a very, very big trial. They took 21,000 people, and it was an RCT, a randomized control trial. So once again, the highest quality of evidence, or highest quality level of evidence. It followed these people for about 3 years, and people were randomized to either take warfarin with atrial fibrillation, low dose edoxaban.
Oh, yeah, sorry, go ahead. I'm sorry, go ahead.
Yeah, Dr. Kenny, you're saying?
Go, I'm sorry, go ahead. My mistake,
Yeah.
Go ahead.
Yeah, so low dose edoxaban or high dose edoxaban. I believe low dose was 30 and high dose was 60 in this trial. And here are the results. I'm going to summarize this chart on the slide just now. Here you can notice we have the risk, or the percent of strokes. In warfarin, it was about 1.5. With low dose edoxaban, it was about the same, a little bit higher, but it's not too much of a difference, so this is not a significant difference here. Both high dose edoxaban, you did have a significant reduction in stroke and embolic event. One interesting finding was that a lot of this reduction a lot of this reduction happens due to hemorrhagic stroke rather than ischemic stroke. So if you remember, the difference, ischemic stroke is where you have a blood clot and you block the oxygen going to the brain. You'll notice that edoxaban, high dose edoxaban and warfarin, they stop the blood clotting to around a similar extent. However, the major difference lies in the hemorrhagic stroke. So edoxaban actually reduces the amount of bleeding that can happen in the brain. So again, you have to balance the bleeding risk with the clot risk, and edoxaban was found to better balance that bleeding risk. So the study overall found that high-dose edoxaban was better than warfarin at reducing strokes. Both low and high dose edoxaban reduced bleeding. However, ischemic stroke was higher on the low-dose edoxaban. So if you are going to be on edoxaban or one of the newer agents, then it's probably going to be at a higher dose as well. And Dr. Kearney, did you have anything to add?
Yeah, so each of these novel agents have gone through similar testing. We all show the same thing, that if you look at warfarin, the old agent, versus the new agents, they both reduce the event of ischemic stroke, and that all four drugs dramatically lower the incidence of hemorrhagic stroke, compared to warfarin therapy. So you have to balance this, and the higher the dose, the better the protection against ischemic stroke, and the higher the bleeding risk. So, and all these agents show this to, edoxaban and Pradax or Digoxin were studied at high and low dose, and both show that the higher dose, so basically if you're at high risk for having a stroke, an ischemic stroke, the best drug right now is Digoxin Pradax, because what happens is it's better at ischemic stroke compared to warfarin therapy, but you pay a higher bleeding risk. It makes sense. If I give you a blood thinner that works better, you're going to bleed more. And unfortunately, one of the bad bleeds is inside the brain compared to warfarin therapy. So if you're at lower risk of, or if you're at high risk of bleeding, then we're going to use probably things like apixaban, or low dose or edoxaban, or low dose Pradax, or a lower dose of Xarelto. So you can adjust that, and it's a decision that you need to make with your physicians, or your physicians will help make that. It's not fair to you as a person to make that decision alone, and the help of stroke experts along the way will really be helpful for you. But the bottom line, if you have atrial fibrillation, you need to be on something, and the something is very much a discussion with your healthcare provider.
Right. And to sort of drill that last little bit that Dr. Kearney said in one more time, if you do have atrial fibrillation, you need to be on something. And we're going to talk about the CHAD score once more. And I'm going to talk about the points here. So again, if you have atrial fibrillation in combination with congestive heart failure, high blood pressure, older age, so even 65, maybe even lower than that, diabetes or previous stroke, there are these point values assigned to these things. With the biggest values being assigned to age, so not only 75, but perhaps 65, as well as prior stroke, and diabetes, high blood pressure, and congestive heart failure all count for 1 point. So you'll notice we have each score up from 0 to 6 aligns with a percent of stroke risk. So if you have atrial fibrillation with absolutely none of these factors here, you are still at 1.9% risk of stroke. However, the second you add on some of these factors, your stroke risk skyrockets. You add 1 on, your stroke risk is at 2.8%. You add 2, it goes up to 4%. If you have pretty much everything here, your stroke risk is about 18.2%. It's almost, you're at a 20% risk of stroke every year pretty much, and that's a scary number. Typically, even just having one of these points is enough of a reason to be prescribed anticoagulation therapy. So that's either warfarin or dabigatran redoxa. So if you have atrial fibrillation and any one of these things, that is at this point in time enough reason to be prescribed redoxa, dabigatran, or warfarin.
Basically, it's saying that this is the stroke risk per year. So if you have all these risk factors, your risk of stroke is roughly 20% or 1 in 5 that you will have a stroke in the next year. That risk is every year. If you have none of these risk factors, your risk is probably less than 2% per year. And so you can actually calculate that. So I don't know about you, is that if my risk of stroke is 5% per year, that's unacceptable. And that's every year. So the lifetime risk for most people with atrial fibrillation is well over 60%. I don't know about you. I'm not willing to take that chance. And you can lower your risk between 60 to 70% by these blood thinners. Yes, you increase your risk of bleeds. I would rather bleed inside my belly than have a stroke. And most of the bleeds are very manageable. I don't want to have a bleed, so that's why you have to balance these effects. But these numbers are real, and the strokes are real. And because these small chambers have big blood clots, they're not small strokes, they're big strokes. And once you've had a serious stroke, your life is never the same.
Yeah. I'm going to talk very briefly, just one slide on cardiac ablation. So ablation therapy involves, it's an invasive procedure, so rather than treatment with medications, it typically involves catheters that are entered through your bloodstream. So they enter it through either, I believe, the femoral artery near your hip, go up your body towards the heart, and they intentionally damage and scar the atria. Now, the atria, again, being these upper chambers, the smaller chambers of the heart, they intentionally scar this. And the reason they do this is it's usually in hopes of resetting or getting rid of problematic areas within the conduction system or within the electrical system. They do this at the same time as an electrophysiology study. So they will actually test different areas and see which areas are perhaps the most problematic, and they will try scarring those areas. And again, this is an invasive procedure, a lot more risks than the risks that are present with medications, and it's usually only considered when there's very little success with medications, or it's a very, very serious arrhythmia or very serious case of atrial fibrillation. Dr. Green, do you have anything to add for ablation?
Yeah, it's very interesting. So ablation is emerging, changing technology. So the people that I tend to send for ablation is that they just don't tolerate their atrial fibrillation. They feel weak and tired. It could be they just don't like being in atrial fibrillation. In that situation, that we learned that the pulmonary vein is usually an area where atrial fibrillation starts, and by either freezing, cauterizing, you can actually break up the pathway, and you can actually prevent atrial fibrillation from happening. A number of patients will require more than one procedure. It requires a number of hours by people that are expert in the field about this. So atrial fibrillation or atrial ablation is evolving at this point in time. But ablation is not a procedure to prevent the use of anticoagulant therapy because it decreases the burden of atrial fibrillation. It's not a permanent situation for many individuals. The best way to treat atrial fibrillation is to prevent it from happening in the first place, which we'll talk about having a normal weight, not drinking alcohol, treatment of sleep apnea, aggressive management of blood pressure, losing weight. But ablation certainly has a role in people that are quite symptomatic. We also now have devices, closure devices to put umbrellas in the atrial appendage, and some people who cannot be on blood thinners as well. So we have lots of different technology, but that's very specialized, and I don't want it to. And we're still learning the role of ablation, how it's evolving. So the procedure has changed. It's going to keep changing over time. But this is an exciting procedure for basically people who are quite symptomatic with their atrial fibrillation despite medical therapy. And its role in people with heart failure to decrease mortality is being studied right now. So we still have a lot to learn right now. But right now, this is just for a few people in my practice.
Okay, so I'm going to pass on to Stuart to talk about lifestyle, some of the things that Dr. Kearney mentioned, like alcohol intake and keeping healthy as well altogether.
Yeah, thank you, Paul, for that very informative breakdown on medications and procedures. At this point in the presentation, as Paul alluded to, I want to talk about something that I think is one of the main takeaways from today's presentation. If you're going to take anything away, I want you to take into consideration the study which I'm about to share with you. So Paul, if you can go to the next slide. This study was conducted, which was a randomized control trial, which essentially means one of the highest indications of research evidence. Because what it does is they randomize these patients, so they go into one group or the other, so there's no bias or any unintended effects that come out of the research. What these scientists were interested in looking at was the effect that alcohol has on atrial fibrillation. Essentially what happened, Paul, if you want to go to the next bubble there, was they gathered 140 patients, and as I said, what they did was that they had all of these patients divided into one of two groups. Now these patients were people who were drinking on average about 10 drinks of alcohol per week or greater. And what they did was that they randomly assigned patients into one of two groups: an abstinence group, where these patients went cold turkey or significantly decreased the amount of alcohol that they were taking within a week, or the control group. And these were the patients that would continue to drink the regular amount of alcohol that they normally would on a weekly basis. And they measured these patients for 6 months. So it was a longitudinal study, and they looked at it for over 6 months. And what they were able to find was that the recurrence of atrial fibrillation, recurrence meaning atrial fibrillation taking place, that lasted greater than 30 seconds was significantly decreased in the group that decreased their alcohol intake. What they found was that 53% of patients in the abstinence group had atrial fibrillation lasting greater than 30 seconds, and 73% of patients in the control group, those are the people that continue to drink alcohol, had atrial fibrillation. And that's a stark difference. So you can see that there's 20% difference between these people in just a 6 months' time. So, Paul, if you want to go to the next slide right here, I think if you just click it one more time, this is something that I think is really interesting. Dr. Kearney showed us some research at the beginning of our presentation where we saw some lines that were kind of overlapping. There wasn't too much of a difference. Here you could see that there was a significant difference between the abstinence group, which is those that didn't drink alcohol, and the control group, those that did. And what they found in this slide right here was that at 6 months, the recurrence of atrial fibrillation that lasted more than 30 seconds took place in 37 out of a possible 51, and it took place in 51 out of a possible, I believe it was around 70 or so. And in other words, what that means was that you can see there's a real difference between the likelihood of having atrial fibrillation in the top slide up here between those who stop drinking alcohol and those who continue to drink alcohol. The bottom slide is really, really interesting. On the y-axis, which is the one on the left-hand side, if you just tilt your head, they have something called atrial fibrillation burden. And what they considered atrial fibrillation burden to be the percentage of time that participants were in atrial fibrillation when they were in this study. And what they found was that about 33 to 34% of participants who were continuing to consume alcohol had atrial fibrillation greater than 5% of the time in those 6 months. However, those who did not consume alcohol, which was the abstinence group, about 40% of participants had atrial fibrillation about 0% of the time. And that's that big burgundy bar right at the bottom that Paul's showing you right there. That's a real significant difference in just 6 months. And I think that's really important to recognize, is that this is one incremental lifestyle change that can have magnificent impact on the long-term likelihood of your atrial fibrillation being managed effectively. If you go to the next slide, Paul, you'll see that there was actually more evidence as well. So I spoke to one study. I found another study online which was taking place in Korea, and what they found was that they investigated almost 10 million individuals who did not have atrial fibrillation. And what they were looking at was their alcohol intake in a week and how it correlated to palpitations and atrial fibrillation. And their main finding here was that the regularity at which one drinks alcohol is also a significant risk factor for atrial fibrillation. There was a number of people who would drink maybe 1-2 drinks of alcohol over the course of maybe a week. And the fact that they were still consuming this alcohol on a regular weekly basis put them at a much greater risk for atrial fibrillation as well. So it's not just a dose response, but it's also the repetition, or how regularly you are consuming alcohol, that puts you at greater risk for atrial fibrillation. So if we go to the next slide, there's some main takeaways that you want to understand from these two studies. And these are just two of many studies out there. And it's that alcohol is the most commonly reported trigger for atrial fibrillation. Essentially, what you want to do is that if you have atrial fibrillation, if you're at risk of atrial fibrillation, you want to completely cut out the amount of alcohol you're drinking, because this is one of the greatest ways that you can help manage your atrial fibrillation. Atrial fibrillation, as a result of alcohol intake, has been linked to a number of other cardiovascular manifestations, including an increased left ventricular size, and of course, as we know, impaired electrical signaling long term. So if you are going through atrial fibrillation, eliminating alcohol consumption is imperative to managing your heart health. And Dr. Kernow, is there anything you'd like to maybe add to that?
I think you summarized something. So atrial fibrillation can be permanent or intermittent. We now have randomized data that in patients who have intermittent atrial fibrillation predominantly, you can actually get rid of probably a third of episodes of atrial fibrillation by not drinking. Now, these people were saying that they drank over 10 drinks a week, and they agreed to participate in the trial. So they were open people and said, listen, I drink. I agree to not drink, but many of the people who agreed to not drink still drank to some degree, but they reduced their alcohol consumption. So we also learned from another randomized trial, which we haven't shown you here, that alcohol affects electrical properties in the atrium, remodeling of the left atrium. It causes more scarring in the atrium, and that leads to more atrial fibrillation. So overweight leads to more pressure in the atrium, more atrial fibrillation. Bad control of hypertension has that effect. You mentioned coffee. I don't think there's really good data about coffee being causal for atrial fibrillation. If you feel palpitation because you drink coffee, fine, don't drink coffee. But I don't think there's really high-quality data for coffee. I think there's tremendous quality data now that, unfortunately, alcohol in atrial fibrillation, unfortunately, is not a great thing to do. Now, if you have permanent atrial fibrillation, your atrial fibrillation, that may be a little different things to think about. But in those people that are troubled by atrial fibrillation, or people that are worried about intracranial bleeds, that alcohol can make that process worse right now. The other important thing is that is losing weight is so important. I know it's hard to do, but these are the things is as we get older, the heart is not designed to pump against all this body weight, this blood pressure. And now we found that alcohol has a major impact as well. So it's excitement that we can do things with, with catheters, with medications. We can also do things with lifestyle changes as well. And they're all quite complementary. And so that's exciting. We know that if you have atrial fibrillation, you're more likely to have silent stroke that we can't always prevent. Again, we can lower about 70% of strokes, but we also don't get rid of them all. And that if you have atrial fibrillation, you're more likely to develop Alzheimer's disease later in life. In fact, any stroke is more likely to cause Alzheimer's disease in the future as well. So I want to protect my brain as much as I can for as long as I can. Wonderful. Thank you for showing that.
Yeah, thank you, Doctor. Next, what I want to briefly touch upon is diet. Doctor just mentioned that a lot of things are supplementary when it comes to managing your health, and it takes a collective effort of diet, exercise, medications, lifestyle changes altogether that's going to help manage your atrial fibrillation. We talked in a previous presentation on hypertension. We talked about something called the DASH diet. And I encourage you, if you have time, to take a look on our webpage and take a look at that video, because I think we went into a lot of great details on some of the important changes that you can make to your diet, which is going to help you in a number of ways, and not just related to atrial fibrillation. Right now, I want to briefly summarize some of those things. The DASH diet is essentially a diet that focuses on fruits and vegetables, whole wheat grains, lean meats, low-fat dairy, nuts, legumes, and seeds. Essentially, what it wants you to do is eat a portion control 3 meals a day that prioritize the things that are going to provide you the most macronutrients, things like potassium, things like calcium, all these things that are important to help your body function properly. And there are a number of different ways that you can get these different things. You want to avoid things like sugars, salts, saturated fats, trans fats. These are the types of things that you're going to find in boxed foods, canned goods, things in the frozen meal aisle. That section right there in a grocery store is not your friend, because you may not realize it, but there is an incredible amount of salt, sugar, and fats in these foods, and not near enough potassium or calcium or other macronutrients that your body needs to sustain itself on a daily basis. I just want to also briefly touch upon that comment I had there about excessive caffeine. Dr. Kearney was talking about there's not a lot of information regarding coffee in terms of having a severe disadvantageous effect on your health when it comes to atrial fibrillation. I, through my research, found something very similar to what Dr. Kearney was saying. There's a lot of information, there's been a lot of research going into coffee, and they say that it's not necessarily disadvantageous. What they did find, however, in a number of observational studies is that energy drinks, or things that are excessively rich in caffeine, these are things that have a lot more caffeine than a regular cup of coffee, can potentially lead to atrial fibrillation. And so I think the main message there is, if you drink things like energy drinks, or if you drink excessive amounts of coffee and you feel palpitations, then that's an important indicator that you should definitely cut back and pay attention to how these things make you feel. Finally, yeah.
Sir, you're absolutely right. You made me remind myself, is the data on energy drinks. There is an association, but I forgot, that because they really have higher concentrations of caffeine, that energy drinks does make rhythm problems worse, and that's based on observational data, but really good observations. That's a very good one. Thank you for bringing that to everybody's attention. I forgot that. Thank you.
You're welcome.
I do also want to throw in that one fact. While we all love coffee, we have to be very considerate with like sugar and cream that we're throwing in there, because a double is 200 calories. Unfortunately, yeah. So while the caffeine itself might not be the worst in the coffee, especially with the DASH diet and portion controls, you do have to be careful with the other things that you're throwing in your coffee.
Good point. Thank you.
Yeah, very good point. And the last point right there, I've mentioned it, but eliminating alcohol intake is imperative to helping you manage your atrial fibrillation. I think if you take anything from this presentation, that would be one of the first things that you should try to implement in your daily life. I know we understand that's a very challenging thing to do, but Dr. Kernu has mentioned that in the past, if you really are concerned about if you think someone else is concerned about your alcohol intake, then that's a reason for you to be concerned as well. Oftentimes you may not recognize it, so if you don't think you have an alcohol problem, it's always important to ask a loved one and to see how they feel. And I think Dr. Kernu has mentioned that a number of times, and I think that's an important message as well. So moving on then to the last lifestyle change that I think is important. This is just, a quick summary again of just the diet there. This is similar to the DASH diet. They say limit your salt intake and try to get as much potassium and calcium in your diet as possible. Lastly, what I would love to talk about is trying to get exercise. A lot of people with atrial fibrillation are concerned about getting exercise. They're concerned about elevating their heart rate. They don't want to exert themselves because they think that that's only going to contribute to the problem. Paul, if you click the next point there, the Heart and Stroke Foundation recommends that it's really important for you to try to maintain regular physical activity, and it can have significant benefits. Now, that's not to say that you need to go out there and run a marathon right away, or you need to overly exert yourself on the first workout you ever try. With precautions, I think it's really important for you to try to integrate as much physical activity in your daily life, but it can be progressive. It can start off slow. Things like taking the stairs, if you're working somewhere, going on a walk, biking, playing some rec sports if you're interested, doing some free weight exercises, just small things that you can do. And if you go on the next slide, Paul, you can see that then you can slowly begin to gradually improve and increase the amount of exercise that you have just by listening to yourself. How is this making me feel? Do I feel like I can handle this? How is my heart rate feeling? Listening to yourself is the most important thing you can do when you're exercising and you're living with atrial fibrillation. So begin and finish exercises gradually. That's a really important one. You don't want to get your heart rate escalated too quickly. So beginning an exercise slow, perhaps by doing a little bit of walking and then picking it up to a jog, if that's something that you're interested in, and then slowly bringing it down to a nice paced walk at the end is important so that you are not overly exerting your heart too quickly. Next, focusing on your breathing. How is this making me feel? And then the final one as well is start off with light exercises if exercises is not something that you normally implement in your daily life. And then as you listen to yourself, you can slowly begin to increase the intensity. Of course, if you have any concerns about exercises, bring them up to Dr. Kernu and we can make a plan that really works for you. And we love to hear about the things that you are interested in as well. So thank you.
So it's interesting that exercise is usually good and it helps control weight, anxiety, and probably helps atrial fibrillation. But there's also an entity in people who are ultra marathoners who do too much exercise. It can actually increase the scarring in the atrium itself, and over-exercise can cause atrial fibrillation. But that's not a very common problem. I have a couple people who are vivid cyclists who run triathlons. In some cases, you can overdo it, but that's very, very rare in my practice.
Okay, thank you, Stuart. That was very informative, especially that key takeaway of, if you have atrial fibrillation, you need to reduce that alcohol intake. I'm going to touch very, very briefly on a little bit of technology. As we all know, the future is now. It's the year 2020. Remember, way back, people thought there would be flying cars in 2020. So we don't have flying cars, so we have Apple Watches that can tell us our ECGs, which perhaps you could say is just as nice. So we have such things that are called ECG watches or portable ECG monitors. There are bigger ones. There are ECG monitors that you can actually bring to your home and you can track at home. However, we know that, if you have atrial fibrillation, you might be having an episode when you're away from home. Perhaps you're at work or you're going for a walk. And this is where these ECG watches are a little bit more convenient. Now, ECG watches are wrist devices, and they have a one-lead ECG in them. I'm going to talk about some of them here. And these are one-lead ECGs. The ones that we do in Dr. Cooney's clinic are 12-lead ECGs. So these ECG watches are not a replacement for the ECGs we do in clinic. In fact, they're not. They only tell us a sliver of the information that a 12-lead clinical ECG can tell us. However, in that sliver of information, it can tell you about presence or non-presence of atrial fibrillation, thankfully. So there are a few options to get these ECG watch options. Perhaps the most supported currently is the Apple Watch Series 4 or 5. Now, these are expensive devices. In Canada, the Apple Watch Series 5, the cheapest model, costs $530. So it's not a casual walk in the park in terms of expenses. However, we should also keep in mind that this isn't an Apple Watch. At least isn't a typical normal ECG watch. It's a very smart, very, very smart watch. The watch itself is almost able to replace smartphones. So that's a comparison to, I guess, how much goes into this watch. On the next slide, I have a little video that shows us how this watch is used to track ECGs. But essentially, if you have an Apple Watch Series 4 or 5, you can sync this with your iPhone using the Health app, and you can take a 30-second one-lead ECG no matter where you are. So context, like Dr. Cooney said, is very important here. And perhaps the thing that stands out the most about the Apple Watch is that it is FDA approved. So this is the only ECG watch that is currently FDA approved. So this is a new bit of technology. Within the next few years, you might see this expand a lot more, and you'll have a lot more accessible and cheaper options available. There are actually some cheaper options. However, the thing is with these options is that they are not FDA approved, but they work on similar mechanisms. They have a one-lead ECG, and you can connect this to your computer or your phone and save the ECG as well. The Samsung Galaxy Watch is perhaps a direct competitor to the Apple Watch, and the GRD one is just a random one that I found on Amazon for $60. However, these aren't FDA approved, but in essence do the same thing as the Apple Watch. Now I have a short video here showing users how to use this. However, before I show the video, I do want to emphasize once again that the Apple Watch is not a replacement for clinical ECGs. The Apple Watch is one lead. In clinic, we do what's called a 12-lead ECG that tells us a lot more information. Also, the Apple Watch, while it is FDA approved, is not 100% accurate. And the fact is, there are a large amount of false positives with the Apple Watch Series 5. So it's more likely to tell you, or it's actually quite likely that the Apple Watch would tell you have atrial fibrillation, even if you don't. I guess on one hand, that's better than having a false negative where it tells you don't have atrial fibrillation when you do. Because if it does tell you have atrial fibrillation, it'll tell you to go follow up with your doctor, and then your doctor can confirm this finding. So it's almost like a suspected atrial fibrillation. If you have a history of atrial fibrillation, it's a little bit more useful. And this video will show you how you can track that.
All right, I am here to do a video on the EKG feature of the Apple Watch Series 5. I have that on my wrist right now. You have to go into your Health app first. So if you open up the Health app, you can go down here to set up ECG app, not EKG app. So the rhythm of your heart can affect your overall health. The ECG app records your heartbeat using the digital crown of your Apple Watch. Once you take a recording, the app looks for atrial fibrillation, a form of irregular rhythm, until you enter your birth date to go forward. So put my birth date in here. How does it work? It records an electrocardiogram, also called an ECG or EKG, which represents the electrical pulses that make your heart beat. The app checks the pulses to get your heart rate and sees if the upper and lower chambers of your heart are in rhythm. If they're out, it's called atrial fibrillation. Fun. Hope I don't have to go to the hospital today. Sinus rhythm means the heart is beating in uniform pattern. AFib, blah, blah, blah. Lower high heart rate, inconclusive. Continue. Should know it cannot detect heart attack, blood clots, stroke, or other heart-related conditions. Doctor.
So that's a key point there. While this can detect atrial fibrillation, it can't detect certain things like strokes or heart attacks. So this isn't a all-in-one feature. This is still very primitive technology. But for some patients that have these, I have seen patients use these in clinic actually. So, let me head back to that video.
Sinus rhythm means the heart is beating in uniform pattern. AFib, blah, blah, blah. Lower high heart rate, inconclusive. Continue. Should know it cannot detect heart attack, blood clots, stroke, or other heart-related conditions. Talk to your doctor if not feeling well. No, I can't sue them. Okay, recording an EKG takes about 30 seconds. First, open the ECG app on your Apple Watch. So let's do that. Take an accurate watch. It needs to be snug on the wrist, selected in settings. Okay, now it's going to ask me to hold my finger on the crown for 30 seconds. It's kind of crazy that you can do this now on a watch. Well, hopefully I'm not having to go to the hospital. Try not to move your arms, okay? I'm trying to record a video here, Apple. Alright, so that was the ECG feature. When you're done with it, you can go into your Apple Watch app and look at the details. You can export a PDF to your doctor, which is kind of cool. So it shows here kind of like at a 73 beats per minute average. Gives you the information about how you recorded it. Tells you what sinus rhythm is. Means that your heart's beating in a uniform pattern. So that's good. So I got a healthy heart. Cool. If you like this video, give it a thumbs up. And
yeah, so that's very briefly how it works. I don't have an Apple Watch, so I haven't been able to try this out myself. But yeah, it's just a very quick way to check your ECG on the go, and you do have the ability to export a PDF for you to give that to your doctor as well, if you ever do catch yourself in atrial fibrillation with this device. Again, this isn't used to truly diagnose atrial fibrillation. In order to do that, we have to look at what Dia taught us earlier today with ECGs or Holter monitors as well.
So there's also the cardiac device that costs $150 to about $200. It's a 3 and 6 lead system. It goes to both an Android or an iPhone. That's also FDA approved, and that can detect atrial fibrillation. If you use things like Fitbit, like what I have right here, it just tells you the heartbeat. It doesn't actually tell you the rhythm. So if you think you might have atrial fibrillation that's intermittent, you can consider that technology. What I'd ask people to do if they think they have atrial fibrillation, that they actually print the strips, and next time we encounter, show the strips. And I'd like to see you in person for that, if you think that happens. So sometimes artifact gets in the way, you can overdiagnose things, but this technology is really something amazing. You know, when I first started practice, is that we had these big 12-lead ECG machines. Now they're smaller, they're slicker. We had Holter monitors for 24 hours. Now we can go up to 2 weeks, what we want to, quite easily with smaller devices. When I first started practice, we didn't think atrial fibrillation caused stroke. Then we had 5 trials that showed that the neurologists were right, the cardiologists were wrong. Atrial fibrillation was a very important cause of stroke, and we learned that we can lower the risk of stroke by blood thinners with warfarin first. Now we have these newer agents that in some circumstances are as good as or slightly better, but they're safer for intracranial bleeds. And so we've come a long way. Now we can try to get rid of atrial fibrillation now with ablation in some circumstances. I don't think we totally get rid of atrial fibrillation with decrease the burden. The biggest problem as we get older is that as we get more overweight, we're going to increase pressure in the heart and lead to atrial fibrillation. And to congestive heart failure into Alzheimer's disease. That controlling blood pressure is important long term. Now we found out that alcohol can make atrial fibrillation worse. So we have lots to do and lots to learn, and we have very effective therapy. And you guys have done a fantastic job of summarizing a lot of information. What are you going to tell us next?
Yeah, so that's actually all we have for today. And we do hope you did learn something new. If you do have atrial fibrillation, perhaps one of the key takeaways is that you should probably reduce the alcohol intake and should, after discussion with a healthcare provider, be on anticoagulant therapy. If you don't have atrial fibrillation, perhaps a key takeaway is that there's a lot that you can do to stay healthy. And stroke is a real concern with atrial fibrillation, so we have to be really careful and very communicative with our healthcare team. As always, if you have any questions, you can leave them in the chat, either on YouTube to the side or on WebEx as well. If you have any questions in the future, you can always email us at drcurnew232@gmail.com. Be sure to check out more videos. We talked a lot about high blood pressure during this webinar. Just last week, we had a webinar on hypertension and high blood pressure. So if you go to our YouTube channel, which is youtube.com, and you just type in Dr. Curnew in the search bar, you can see some of our other videos, and check out our website at drcurnew.com as well for a list of events or anything that's going on. Yeah.
So we went through a lot. Remember, if you think you have a stroke, call 911, get to a hospital very quickly, specifically if you can to a stroke center. This is wonderful. Thank you so much for sharing all that. And what's going to happen is that in about half an hour, 40 minutes from now, I'm going to be at the Shadok Stairs. That's the Shadok golf course, and we're going to go up some stairs for people who want to. We're planning to do these after these webinars if you want. This Saturday and Sunday at Linden Park in just outside of Hamilton. We're going to play some tennis at 6:30 in the morning, go for a bike ride at 11 o'clock. Everybody's free to join. I want to thank everybody for participating. Any questions or comments we see from anybody? One thing I want to give a special thanks to Sonia, who's worked very hard behind the scenes of making the website better. It's going to be faster, slicker. She's also calling people and helping people with their technology. She's done a wonderful job. She calls on Friday nights and Saturday mornings. So, and with the rest of the teams involved, there's so many people to be thankful, and I want to thank everybody for presenting it. Is there any, Stuart, any questions or comments you see on YouTube at all, or anybody questions on WebEx have a question or comment?
No questions in the WebEx. Some people just sharing their family experiences, and let me check YouTube.
So if you have atrial fibrillation and have any rhythm problems, one of the things is that we evaluate the heart. One thing is we do the ultrasound test to just look at the structure of the heart. We can actually figure out the pressure of the heart. In fact, my father-in-law, I just saw today and yesterday, he's had atrial fibrillation for a while, and all of a sudden his heart rate got lower, and he was back into normal heartbeat, so we had to change his medications. On his ultrasound test or his echocardiogram of the heart today, we found that his left atrium is really very big, and there's not much atrial contribution to his cardiac output, so we know he's going to have more atrial fibrillation over time, so we learned a lot. So I want to wish everybody a good night. For those that want to stay on, we're going to just have a little wind down session. For those that are finished, have a great night, and we'll see you next week. Thanks again, everybody, and thanks everybody for
Thank you so much for joining us.
And thank you for coming, everybody. We'll see you soon, okay?
Bye, Paul.
Have a great weekend. Bye-bye.
Bye, everybody.
Bye, Paul.
Oh, yeah, sure.
Okay, bye, Dr. Deacon.
How are you?
Yes.
Good, how are you?
Hi, Greg.
How's it going?
Hey, how are you?
Good.
Is the camera on?
I don't have a camera, but
okay.
this was wonderful. Again, I just it's thrilling to listen, and I learned something every single time.